Thanks. Good morning, everyone. My name's Rasha, and I'm a nurse practitioner with the Global Health Program at Boston Children's Hospital.
Good morning, everybody. I'm Dr. Ala Al-Halawani. I'm a pediatrician here at the IMC Hospital in Azraq camp.
And this presentation is going to describe a project aimed at capacity building and strengthening of pediatric emergency care in the Jordanian refugee camps. We don't have any disclosures. All right, so we're just going to spend the next 15 minutes describing a partnership between Boston Children's Hospital and International Medical Corps with the aim of strengthening pediatric emergency care and trauma care in the Jordanian refugee camps.
Okay. I'm going to talk briefly about the camps available here. I'm with the International Medical Corps. They are basically in two major camps, Syrian refugee camps here in Jordan. The first one is Al-Azraq camp, where I work. We have a hospital, a 24/7-hour hospital with emergency 24/7 emergency care. We have pediatrics ward with also a gynecology and obstetrics ward. We have limited capacity for admissions for non-serious cases, and we take care of neonatal babies and emergency care for the neonates, and also for obstetrics, as well as the emergency care, as I mentioned before. The other campsite is a Zatari camp. There's a 24/7 emergency care center. It's not quite a hospital with no admissions, but it is a 24/7 center with the major services, as well as a camp, limited to 8-hour periods for the x-rays and the laboratory.
As most of us learned today, the recent budget cuts and staffing constraints have significantly affected humanitarian care, and especially pediatrics. As a result, a partnership was formed between Boston Children's Hospital and International Medical Corps to meet the identified educational needs of local staff, increase clinical expertise in caring for pediatric patients, and strengthening pediatric emergency care capacity.
So I'm going to talk about the challenges we're facing right now at the camps. At the base of all our problems are the budget cuts, especially with the slow resolution of the Syrian situation right now. We have had some serious budget cuts affecting a lot of the care we provide for the patients. So it has affected resources, it has affected our ability for staff hirings, for providing medications, and among other things. First of all, as I said, workforce limitations. We have had a lot of staff cuts. Right now at the Azraq camp, there's only a single pediatrician 24/7. There's only one paramedic 24/7. One GP 24/7, an anesthesiologist, and a gynecologist. We have had a recent limitation in the period for the radiologist assistant who takes care of the imaging. So we have had severe limitations in the workforce we had. The other problem is the medication protocol guideline limitations. First of all, we have a very limited number of medications available. We do not have all the medications that we need to care for our patients. Most of the very, very emergent medication are available. However, some of them are not, and they're not within the major drug lists that are allowed to be entered into the camp. Also, the other thing is the mental health strain. With the budget cuts and the inability for referring the patients and giving them the proper care, we're having severe stress on the patients themselves and their families. We deal with pediatric cases, and we have to deal with not just the patient but the family of the patient. The inability to refer the patient, we are now limited to life-saving referrals only. So diagnostic referrals, chronic case referrals to specialty clinics are extremely limited right now. We are unable to provide the services we used to have before. So that creates excessive strain on the families, and makes them get aggressive. Some of them have had depression because That's what they can. And the last issue is the lack of ongoing training, which is now a little bit being resolved by our collaboration with the Boston Hospital.
Oops. Yeah. As such, we identified 3 core priorities to help with the gap. So the first was a clinical priority, which includes the need for training with regards to recognition and management of the injured child, neonatal and child resuscitation, post-resuscitation and trauma care, and then context-specific evidence-based practices, clinical care guidelines, and protocols for common pediatric conditions. The second domain will focus on mental health support, so looking at tailored approaches to assessments, care, and management of common mental health conditions in children and adolescents, and the final is sort of research support. For the clinical domain, we identified 4 areas that need training. So we discussed 4 in-person intensive trainings, which included didactic sessions and case scenarios. We completed 3 of these trainings already, with one most recently earlier this week, and have 1 more to go. All of the training sessions included skills competency development, so hands-on workshop sessions using low fidelity simulation, tools to cover primary emergency skills and teamwork. For the mental health capacity building, we discussed, first aid training for healthcare workers, educators, and community leaders, including trauma-informed care workshops tailored to pediatric and general populations. We're looking at basic counseling skills for frontline providers and a review of common mental health conditions. And we're trying to collaborate with the Ministry of Health for education and tool validation. Unfortunately, because of the budget cuts, we have not been able to start with this domain, but it's coming. And finally, we discussed research support. So we'll be providing support with topics including research methodology, design, data collection, statistical analysis, and interpretation. We have a data agreement in place now between both centers to be able to share information, and the next step will involve discussing research questions and potential processes to monitor. Finally, we established working groups, including at least 1 physician and 1 nurse from both camps, to develop and implement guidelines and protocols. The priority protocols were identified by the local staff, and we are working together as a group to come up with the guidelines with existing International Medical Corps guidelines and WHO standards. And we just completed our first protocol, which involved the asthma management guidelines in inpatient and outpatient settings, which we are hoping to pilot in the next few months. In terms of, with regards to sustainability, we identified 2 nurses and 2 physicians from each camp, which will be the pediatric champions. These clinicians will receive extra training to facilitate future course offerings, including leadership, medical nursing education techniques, and evidence-based and adult learning approaches. These clinicians will in turn facilitate identifying learning needs, co-leading monthly education sessions, and disseminating information with regards to professional development opportunities. Of course, no program is complete without M&E. In the long term, we'll be looking at impact measures, childhood outcomes, numbers of referrals, transfers. For now, we are tracking system measures, so numbers of workers trained, program components, provider perceived competence, knowledge, and behaviors. We'll be looking at care providers, providers' use of interventions, number of protocols, and disseminated educational materials. I'm going to share with you some of results from our February training. So we had approximately 45 clinicians who received or joined that training. We looked at knowledge gained using pre and post tests, and we found that the mean score difference between pre and post tests were about 16.7 points, with 91.3 participants showing an increased score at post-test. We also looked at confidence improvements using pre and post surveys and skill checks, objective skills checks, and some of these results. We had 94% of respondents felt like they have the ability to recognize a critically ill child, 100% felt more prepared and had an organized approach to care for critically ill children, and 94% felt more confident participating as a member of an interdisciplinary team. We also collected anonymous course evaluations, which showed that 100% of the respondents felt that the learning objectives were met and teaching was relevant to their practice. Evaluations praised a lot of the hands-on stimulation and requested ongoing mentorship. Just to summarize, the initiative presented here is an example of how successful partnerships and collaboration can improve pediatric quality of care and emergency capacity. I know that we at Children's are very excited to continue this collaboration and support the needs of our colleagues. Thank you.